Good morning, good evening, ladies and gentlemen. Welcome for today's webinar, Social and Behaviour Change for HIV. It is a highly anticipated webinar, and I believe you're all excited and ready to learn and hear from our dear panelists and experts who have what is being prepared for us. I think, as we know, HIV continues to be the major global health issue, impacting millions of lives every year. Yes, we have made some significant strides in treatment and prevention, but the battle is still far from over. Looking at how many years you can call if we are to talking about reaching epidemic control. We have about at least 6 years from now, but still understanding and addressing the social behavioral aspect of HIV is still essential to our ongoing efforts to combat this epidemic. So, why SBC? SBC targets cognitive, social, structural drivers of change and creates the enabling environment required for change. This evolution will definitely signify a new era in HIV prevention, and one that promotes a healthier lifestyle that through informed choices and places beneficiaries at the center of the health journey. And now, if we can recall, on the last SBCC conference in Morocco in 2022, the movement which was led by the Global Alliance for SBCC, UNICEF, and other implementing partners, we built a case for broadening tools and approaches used for social and behavioral change beyond communication. Now, given the crucial role of SBC plays in HIV prevention, the need for program implementers to apply only evidence-based SBC approaches to support HIV prevention outcomes has become an urgent, especially in this era of where we talk about precision programming. Now, today we are delighted to have another webinar that is going to reflect on SBCC, going to review a bit of SBCC effectiveness in HIV prevention, and stimulate discussion and thought, around new narratives for combination prevention and demand creation for HIV services. So I'd like to welcome you all in this webinar. And if you can see on our screen, for those who are English speakers, you can just type or click on the interpretation button there, and it will lead you directly to where you would prefer to use the language or hear from the communication. And also we're going to have the Q&A box, so please feel free to drop in your questions, and we'll be gladly to respond. So we are moving to the next part. We have a Mentimeter, which we're going to, there are two questions that we're going to ask. If the Mentimeter, yes. Yeah, thank you. So you can just use your phone and just scan this QR code, and then it will lead you directly to these two questions. And then from there, we'll be able to answer and provide some of your insights. So you can just scan, and then, yes, you can see the questions. Number one, how important is SBC to HIV prevention? And number two, it's mention 3 words that come to your mind when you think of social and behavioral change for HIV. Now we're going to give you like 1 or 2 minutes to respond, and then we'll hear from what are your perspectives based on the answers you've provided from this Mentimeter. And we're going to provide the Mentimeter live and so that you may all see what are our responses in regards to those two questions. Okay, the clock is on. Just 1 to 2 minutes. Just checking my clock here. Okay, thank you. So now we are live on the Mentimeter, so you can see the responses from our audience there. That, for instance, the first question says, how important is SBC to HIV prevention? You can see the large majority have answered very, very important, and a bit on the important is still, and the third one not sure, and the fourth one not important, but rather the first, the majority have said it is very important, the SBC in HIV prevention. Can we go to the second one and see how have we responded? Okay, now, so back to you. You can still scan this QR code, and we want to hear from you the 3 words that come to your mind when you think of the social and behavioral change for HIV prevention. We'll be waiting just for 30 seconds, and then let's hear what you have to say from your side. Welcome, everyone. Wow, thank you so much. Okay, underfunded, difficult to measure. All right. Keep coming in. I see some answers. Change. Wow, that's nice. Norms. That's so delightful. That's so delightful. That's so delightful. Choice, difficult. Yeah, I see many have written change. Yes. Stigma, empowerment, advocacy. Wow, thank you so much for your responses. I think for the interest of time, you keep answering these beautiful 2 questions, and then I see change and stigma. Yeah, thank you so much. So at least we have a word, at least 3 words that we can see, or that comes to our mind as far as social and behavioral communication is concerned. So thank you for everyone for your participation on the Mentimeter. We are really, really delighted. So we're going to have presentations from Brian Pedersen, and the topic will be on effectiveness of SBC for HIV prevention. And then probably let's see a bit of who is Brian, then he will continue. Brian is the Social and Behaviour Change technical panelist with over 2 decades of experience in public health, and he is currently a technical advisor with FHI 360, where he provides technical support and guidance to co-design and co-deliver with stakeholders theory-based, evidence-informed interventions to enable adoption to healthy behavior. And after Brian, we're going to have a session with the Q&A that will be led by Dr. Warren. But for now, let's hear from what Mr. Brian has to say and has to present to us. Welcome, Brian. Thank you.
Great. Thank you so much, Dr. Ona. So just to begin, I just wanted to thank the Learning Network for having invited FHI 360 to make this presentation. I think many of you who are on the call today probably could make this presentation just as well. So again, we're very thankful to have been invited for this opportunity. Next slide, please. So the sort of remit that I have today with you all is really to make you believers in the importance of SBC interventions for HIV prevention. I see from the Mentimeter, I don't have a lot of work to do because it seems like many of us already understand the importance of SBC interventions. So maybe what I can hope to achieve by the end of today is to understand and be, advocates for the importance of SBC interventions in HIV prevention. I'll be talking a little bit about what is SBC, which again is probably review for many of you on the call today. But it's important to make sure that we're on the same page in terms of what we mean by SBC. We'll be talking a little bit about why SBC interventions are so important at this time in HIV prevention. And then finally, walking through a couple of examples of where SBC interventions have really made the difference in terms of helping HIV prevention programs achieve their results. Next slide, please. One quick disclaimer. This is a big topic. I will definitely be oversimplifying many different aspects of SBC. As a technical discipline, SBC is complicated and there's a lot of gray areas. It's one of the exciting things about SBC. We're constantly learning, we're constantly adapting, but that means that I'm going to have to oversimplify in many cases. And also, I know in advance that there are going to be some really important articles, some great points, some great examples that we will have missed. But again, here, I think the objective is just to give you a taste of what's out there and again, highlight the importance of SBC interventions. Next slide. So let's start with what is SBC, getting us all on the same page. So next slide. I spend a lot of my time explaining to people what is SBC and what is the importance of SBC interventions. And so usually when I'm making a presentation to colleagues about SBC, I like to start with this little quiz, just to get a sense of where we are in terms of our understanding of how behavior change happens in most of our programs. And so, without putting it in the chat, just for your own purposes, nobody's going to be correcting you later. When you look at these 6 different interventions that are listed here, so supply chain management, service quality improvement, health communication, laboratory strengthening, policy reform, health worker training, which of these interventions do you think could result in behavior change? So I'll give you a moment just to reflect on that. Don't put your response in the chat just yet. I just want you to reflect on that for a moment before I talk a little bit more about SBC, and then we'll come back to this quiz again. So next slide. So I think oftentimes when people think about behavior change, we often assume, and I think traditionally assume, that awareness is enough. That if we put up a poster in a clinic that says, take your PrEP, people will see that poster and they will automatically accept PrEP. It's a common assumption. It's something that I think our field has assumed for many years. And actually, there may be some people on the call today that assume the same. So again, this thought that awareness alone is going to be enough to get people to change their behavior. Next slide. But to understand whether that's true or not, we just have to look at our own lives, look at our own experiences as people. Many of us on the call today probably know that eating sugar or eating sugary foods can actually lead to tooth decay. So it's something that most people know from the time that they're a child. But my question to you is, how many of you still today, this morning maybe, put sugar in your coffee or your tea, or maybe at lunch, took a little bit of pudding or took some other sugary dessert? So you know that sugar can decay your teeth, but yet you're still consuming sugar. Next slide. Another example might be that many of us know that eating food or eating diet that is high in fruits and vegetables is one way to reduce our risk of a heart attack. But again, I would wonder how many of you last night at dinner or maybe today at lunch loaded up on vegetables and made sure that vegetables were the primary source of food in that particular meal. So again, I think the point here is that knowing that sugar decays your teeth, knowing that a diet high in fruits and vegetables is good for your health, doesn't necessarily mean that you're adopting those behaviors. Next slide. And the reason for that is pretty simple. Behavior is driven by more than awareness. Again, this is probably obvious for many people, but sometimes we forget this. And the reason for that is sort of three sort of big ideas. One being that, as human beings, we process information differently depending upon our needs. So a lot of times now we're talking about the fact that we have two different ways of thinking. One way of thinking is very fast. And so we're able to make quick decisions just based on experience, intuition, our gut. And then there's another part of our thinking where we take information in, we process this, we analyze it, and we make a very deliberate choice about what we're going to do. An example of this might be spending money to buy something new. So a lot of people, when they're buying, say, a new car or they're buying a new pair of jeans, they may do a lot of research to really understand if they're getting the best value for money in order to make that decision. In reality, there are a lot of decisions that people make without doing that same level of analysis, that same level of analytical thinking, because it's going to be their decisions are going to be based much more on their gut feeling. Another thing in play here is that human beings in general, we're social beings. We care about what other people think about us. We care about what other people are doing. Many cases, we are like the people we socialize with. And so I think a lot of times we ignore the fact that the social norms around us, the social behaviors around us have a much greater impact on what we do as human beings than what we know. And then finally, behavior is really a response to our surroundings. The policies, the built environment around us has a lot of influence over the decisions that we make and the behaviors that we adopt as people. So again, behavior change is a lot more than just raising awareness because of these three sort of essential ideas about what influences the decisions that people make. Next slide. So in reality, behavior change looks a lot more like this. It's messy. It's complicated. Sometimes it's difficult to predict. Sometimes it's difficult to understand. And there's a lot of back and forth in the way that people make decisions. But again, just because it's complicated doesn't mean it's not possible to change behavior if we think about all the different factors that are influencing why someone does or does not adopt a particular behavior. Next slide. I would love to say that our discipline has known this for decades, but in reality, we're still learning. Back in the 70s, that's when sort of our discipline emerged as a unique area of expertise, where we talked a lot about information, education, and communication. And this was a very top-down approach to behavior change, where we assumed that if experts could communicate to people about what they should be doing, they would adopt it. Again, there are still many people talking about IEC, but again, this was sort of the beginning of our field as a specific discipline. Also in the 70s, around the same time, we started to see the emergence of social marketing. I like to call it classic social marketing because I think today when people think about social marketing, they think about the distribution of products at subsidized prices. But if you look at the classic social marketing, it was very much focused on taking experiences from the commercial sector and applying them to the public sector. So really understanding who our consumers were and building programs around their needs and their realities rather than being so expert driven as we were with IEC. Over time, our field evolved into what we call behavior change communication, which again, forced us to focus on specific behaviors that we wanted to promote. But many times it was focused at the individual level. As a result of that, we evolved to be called social and behavior change communication, which again, still thought about behavior as an essential component, but was taking into account more the social norms and the social drivers of particular behaviors. But even in this case, we were still focused a lot on communication as the main vehicle to achieve behavior change. Which brings us to today, where we call ourselves Social and Behavior Change, which still considers communication as an important component to achieving behavior change, but also takes into account all of the other things that are often way beyond the reach of communication to change in order to create the conditions around individuals, around households, around communities, so that they can adopt behaviors that lead to better health outcomes. Next slide. So how do we define social and behavior change? I'm sorry to say that there are almost as many definitions of social and behavior change as there are organizations working in behavior change. But there are a couple of things that sort of pop out of those definitions as sort of themes across that I think could create a global understanding of what we mean by social and behavior change. So to begin with, social and behavior change is a discipline. It's just like medicine. It's just like pharmaceutical sciences. It's a discipline that requires training and understanding of all the different models and theories that we use. And really what we try to do in this discipline is understand human and societal behavior and apply those systematic or those insights to really understand why people do and do not behave in certain ways. As a field, as a discipline, we try to make sure that we're addressing not just the individual level factors that influence behavior, but also understand and address the social factors as well as the structural factors. One thing that I think is very unique about our discipline is that we really try to not just leverage scientific knowledge, but also community insights. So a lot of the work that we do is about working with communities to help them define and do the design of the social and behavior change programs that are being implemented. One thing that is also very unique about our field is that we have a lot of theories and models that help us to figure out what are the best approaches that can be used from communication, behavioral economics, psychology, sociology, in order to, again, create those conditions around households, around individuals, around communities that make it easy and preferable to adopt certain behaviors over others. The next slide. So I would say if there's one model, next slide, please. If there's one model you remember from this presentation or this discussion, it's this one, the socio-ecological model. This is something that I would say is a core model of our field because, again, it forces us to understand that individuals aren't always in full control of making their own decisions and deciding on which behaviors they're going to adopt. And so it recognizes that behavior is really influenced by a lot of different levels. One other thing about this model is that it really emphasizes the interconnectedness of all of these levels. So change at the community level affects change at the individual level. Change at the individual level can affect change at the health system level. And so by understanding all of these different levels and the way that they're interconnected, it forces us to consider much more holistic approaches to understanding and also addressing behavior change. This is, like I said, this is a core model that we use in social and behavior change, and it's typically used in partnership with other SBC theories and models to design not only our formative research, but also the programming that we use in order to facilitate behavior change. Next slide. So I'll go back to the quiz. So looking at this quiz again, and you're thinking about what are the different things that can influence behavior change, think back to what you originally thought and think again, and let's see what the correct answer would be. Next slide. And actually, this is a trick question. Again, I like to put this out there just to make people aware that, you know, behavior change and the way we facilitate behavior change has a lot more to do than just health communication. And in fact, oftentimes when we're working with programs that aren't used to working with social and behavior change, we often make the case that any program that's involving people will ultimately be asking those people to make a change in either a practice or a behavior. And so as a result, we're all working in behavior change if we're working in the space of trying to improve the lives of people. And so the interventions that we use, whether it's health system strengthening or it's communication or it's provider training, all of those different interventions and what we use will change depending upon what our program goal is, what resources that we have, and also what context we're working in. So next slide. So why is why is SBC intervention so important in HIV prevention? Next slide. Well, put simply, we're in a new area of HIV prevention. You know, at the risk of dating myself, when I started working in HIV, All we had to offer people was abstinence, be faithful, use condoms, and also STI screening and treatment. But there really wasn't a lot of options for people in terms of what they could do to prevent HIV. Today, we have a lot more options and many more coming online by the year. So there's just a lot more things for people to consider when it comes to what they can do in order to reduce their risk of HIV acquisition. There's also growing interest in using SBC programs to do more than just create demand for HIV prevention. There's more talk about how we can use SBC to create supportive norms, how we can use SBC to change gender norms, and also how we can use SBC programs to increase individual and collective agency to do things beyond just adopting a certain package of HIV prevention methods. And then finally, there's just been a much greater recognition in the structural drivers of HIV vulnerability. So if we're really going to achieve our HIV prevention goals, as stated in the Global AIDS Strategy, we need to do more than just drive people towards products. We also need to address some of those underlying inequalities and structural factors that contribute to HIV vulnerability. And SBC interventions have an important role to play in that space. Next slide. So I guess the point I'm trying to make here is that, SBC interventions are going to be absolutely essential to enabling informed choice, as people need to decide what they can do to reduce their vulnerability, or they need to take action to reduce their risk of HIV acquisition. We need to be there and provide them with the tools, with the tools they need in order to make their own decision. We need to stop this game of telling people what to do and focus more on providing them with the ability to make an informed choice for themselves. Next slide. So very quickly, what does the evidence tell us about what are the different factors influencing HIV prevention behaviors? Well, again, we've talked a lot about the individual level, but here we're talking about awareness, perception of HIV risk, skills and efficacy to use and negotiate the different options, as well as attitudes and the power to make their own decisions. So these, I think, are a lot of the things that we typically focus on in our SBC interventions, because again, historically, we've focused maybe a little too much on individuals. Next slide. If we bump up to the interpersonal and network factors that drive HIV prevention behaviors, that's where we're talking more about social, peer support, power and equity in relationships, the social network, but also communication in relationships. So just taking one step out from the individual, you can see how there are many more dynamics that we need to understand and address in order to create space for people to adopt HIV prevention behaviors. Next slide. At the community level, again, peer pressure, stigma and discrimination is huge in the HIV prevention space, and I think we've ignored it for probably too long. So HIV-related stigma, stigma related to the behaviors of people, but also stigma related to their association with certain groups. Culture or cultural norms, social gender norms, all of those things are in play at the community level to influence whether people adopt or do not adopt certain HIV prevention behaviors. Next slide. And then at the health system level, of course, availability of products, confidentiality, privacy, provider attitudes, convenient access, all of these things can prevent someone from actually adopting a behavior that could reduce their risk of HIV acquisition. I can do all of the best work in SBC in the community, at the household, at the individual level to convince people to access a certain service. But if they show up and they're not treated well, if they're concerned about the confidentiality of those services, if the product or service isn't available at the time that they arrive, they're not actually able to adopt the behavior that I've just spent the past several months promoting with them. And last slide. Finally, at that structural level, this is where we talk about access, cost. Public policies and laws have a huge impact on the behaviors that people will ultimately adopt, but also enforcement of those laws, as well as gender equity and how that is communicated through public policies and enforcement. Okay, next slide. So just very quickly in summary, and I hope this is clear by now, behavior is driven by more than awareness. It's driven by more than individual will. Most of the factors that influence behavior, especially HIV-related behaviors, and many times it's beyond the control of the individual. So we need to stop focusing on the individual as the only thing that needs to change when we're trying to affect or improve HIV prevention outcomes. And again, I really feel like HIV interventions today need to focus on how do we enable informed choice more than just focusing on that individual awareness, especially in this era of so many different HIV prevention choices for individuals and households. Next slide. So now I'm going to take some time to very quickly go through what has worked in HIV prevention. And again, I'm going to sort of fly through this because I feel like many of you are already convinced, but I just wanted to make sure that we understand what the evidence says in terms of how SBC interventions have worked at all these different levels to enable HIV prevention. Next slide. So let's start at that individual interpersonal level. Next slide. So very quickly, Coach and Pilo, in fact, I think there are some people on the call today that are associated with Coach and Pilo. It's a really great program out of South Africa that was based on this idea that men fear social death more than HIV. And as a result of that insight, they were able to design a program that took men living with HIV that are in treatment, brought them up as coaches who could then provide not only living proof of thriving in an HIV treatment program, but also supporting those men to disclose and stay connected and return to care after discontinuation. Next slide. It was a pilot that was conducted over 7 months. They did a pre-post intervention comparison. They did self-report of treatment status and also did assessment of participants' outcomes, looking both at impacts for newly diagnosed versus previously diagnosed clients. And what were the results of this intervention? Next slide. So the first, which I think is just remarkable, is how many men wanted to be part of this program. 92% of the men that were approached and invited to join the program said yes. And I think a lot of times we assume men don't want to be associated with things like this, but this program shows that if done right, it can actually result in high uptake. What they saw also is that they had very high short-term retention in both groups, which is great. And also for those men that had an interruption in service, most of them, the vast majority, 82% returned during the pilot, and most of those were actually during the within a 2-month period. And by the end of the pilot, they found that 95% of participants reported active engagement in treatment, which is vast improvement over what was done before. Most programs were only seeing about 64 to 69% retention, but in this example, in this pilot, they were able to achieve 95% retention just by making sure that men felt that they were being supported to link and maintain their engagement in a treatment program. Next slide. Another quick example around peer support specifically for PrEP. In this example, what they were trying to address was low peer support for PrEP use. They, again, looked to engaging young women as ambassadors. They were trained in information around what is PrEP and how to facilitate discussions with their peers to encourage PrEP use and create social and peer support for PrEP use. Next slide. The evaluation here was again, another pre-post intervention, and they were looking to see if there was a change in uptake of PrEP use by AGYW. Next slide. And here what they found was not only a great improvement in knowledge, confidence, and ability to speak about PrEP amongst their peers, but also an increase in the average oral PrEP initiations during the pilot, and seeing a greater proportion of clients using oral PrEP coming from AGYW population. Next slide. Let's quickly talk about an example of community level interventions. Next slide. This one is from Tanzania, where the challenge there was that religious beliefs were often impeding acceptance of male circumcision. So this program engaged religious leaders as advocates for male circumcision by training them and building their skills to talk about male circumcision with their congregations. Next slide. I think what's really unique about this particular case is that they actually used a randomized trial in order to evaluate the impact of this intervention on uptake of male circumcision services. Next slide. And what they found there was that in those intervention villages, so where religious leaders had been engaged to promote male circumcision, men in those communities were 3 times as likely to be circumcised as men in the control villages. And what's really interesting here is that there was much more church discussion and much more encouragement from wife and girlfriends to get circumcised than in the control villages. Next slide. And then finally, I wanted to just give one quick example about how social and behavior change interventions have been used to change health system. So next slide. So in this particular case, the challenge that they were dealing with was the fact that HIV-related stigma undermines HIV prevention strategies. So here they used a all-of-facility approach to reduce stigma, so training staff from across the entire health system or clinic to make sure that they understood the importance of confidentiality, they understood HIV stigma, and they understood their roles in ensuring the privacy and confidentiality of clients. Next slide. Here again, they used a cross-sectional survey across 5 intervention and 5 comparison facilities across 5 regions, and used a survey tool in order to measure different outcomes of the program. Next slide. And just to say, they had great improvement across the board. The most important, I think, was the fact that they saw a 19-point improvement in what they saw, what people felt they actually saw happening in these clinics in terms of how PLW HIV were treated when they came into the health facility. And then finally, very quickly, because I've already gone over my time, if we go to the next slide. Next slide. How SBC can be used in order to reduce structural factors that contribute to vulnerability. In this case, they were working with female sex workers to empower them to join support groups and form their own community-based organizations. They also trained government development and police departments in order to make sure that they understood the legal rights of FSW to access services. And they also conducted media training in order to improve how FSW and HIV were being reported in the media. Next slide. Let's go ahead and jump to the next slide just so that I can make sure I don't take up too much more time. But again, what we saw from this example was a dramatic improvement in the number of female sex workers participating in organizations that gave them collective power to demand their rights, from 8,000 to 37,000 FSW participating. And again, here, I think what's really important is that by empowering female sex workers to demand their rights, we actually saw an increase in accessing entitlement services that are provided by the government that they had previously been discriminated against accessing. So again, this shows how SBC interventions can not only affect individual change, but it can also be used to affect structural change in order to reduce vulnerabilities to HIV infection. Next slide. So just very quickly in summary, next slide. SBC is a discipline. We love theory, we love evidence in order to understand factors and address those factors to influence behaviors. We have our greatest impact when we work across multiple levels of influence. So again, remember the socio-ecological model. And there's lots of evidence out there that SBC interventions play a critical role in HIV prevention programs, not just in reducing the risk of HIV acquisition by promoting products and services, but also reducing HIV vulnerability by addressing those social and structural drivers that make individuals more likely to be exposed to HIV. And next slide. So I guess my final word here before I wrap up is to really encourage us as a field of HIV prevention practitioners to apply, for lack of a better term, an SBC lens when we're designing our interventions. And I really think it could be a game changer, because if you think about it now, in fact, I was just on a call yesterday where this was the question people were asking is, how do we expand access to oral PrEP? When we ask that question, we limit ourselves to thinking about the supply side factors or that influence behavior change, but we completely ignore all the other factors that might be more important to determining whether someone is going to uptake or not an HIV prevention product or service. And I really hope that moving forward, as we're thinking about HIV prevention programs, the question we're asking ourselves is more, how do we enable more people to adopt this particular HIV prevention behavior? And when we frame the question that way, it opens up a whole world of avenues of exploration to understand why people may or may not use our service, so that we're focused less on getting the service everywhere and more focused on where do we need to be putting the service, what are the social and structural factors that we need to focus on in order to ensure that individuals can adopt the HIV prevention behavior that we are promoting. So thank you very much. Apologies that I went a little bit over time, Dr. Ona, but let's go ahead and see if we have any questions that I can help clarify.
Okay, all right. Thank you so much, Brian. That was very insightful. I will not add anything for the interest of time. Let's move to the next Q&A session. And then we have Warren Parker, is a public health and communication specialist with over 30 years of experience contributing to HIV and health internationality. He has done a lot of research on media methodology, which he has also developed some of the early responses in HIV epidemic in South Africa. So over to you, Warren. And just to encourage our participant, please just drop in the question in the Q&A section, and Brian will be glad to respond. Yes, over to you, Warren. Thank you.
Great. Thank you so much, Dr. Ona. And thanks, Brian, for taking on the challenge of providing very important insights into SBC in the background presentation. It certainly has lifted out, I think, into everyone's understanding the key elements and issues related to SBC, and then also to the team for organizing this very important session. So I think, as we've seen, as Brian outlined as well, social and behavior change has got a long history of different ways of thinking about how you change behavior, but also how you change social context, norms, and the things that influence behavior. In the HIV field, there's been a kind of trend towards biomedicalization of HIV prevention response and HIV in general, largely led by the understanding that if one sets up the goal or the targets around 95, 95, 95, which is a treatment-oriented approach, you can also impact prevention. And that also led, I think, to a lot of the behavioral aspects of HIV prevention going towards the biomedical model. And if we look at the history of HIV response, a lot of the early responses were really much more oriented around social and behavior change. And now we're looking more at social and behavior change for demand creation is the theme here. But I think also just to stress that that a lot of the important elements of preventing HIV infection include behavioral elements that are not directly related to a service or a commodity. So, for example, delaying sexual debut, reducing your number of partners, avoiding older partners if you're an adolescent, and so on. And there are many other elements if we think about HIV prevention as being something that applies to general populations, adolescents, and key and vulnerable populations. So overall, we need to be focusing on these broader domains as well. But as Brian has outlined in the presentation, SBC has a lot to provide in terms of theory, models, and practice for responding to HIV prevention. So again, if we think about what the global challenge is, one of the key things is that we are behind in preventing new HIV infections by a quite considerable proportion. There are only about, I think, 11 or 12 countries that are close to achieving the global HIV prevention targets at a country level. If we think about the target as being attaining something over 80% reduction from 2010 in terms of HIV incidence. So there's a challenge there for many countries, and we need to hone in on what are the things that we're going to do or can apply, or tools and resources that we have to prevent new HIV infections. So our panelists today are going to cover some of these areas, and then there's also 10 minutes afterwards for discussion and questions. So do put your questions in the Q&A section of the Zoom interface. So we're going to start off with the first presentation. As I understand it, they're not going to be necessarily PowerPoint presentations, but discussions from each person's perspective. And our first presenter is going to be Dr. Daniel Ndukwe, who's a community health physician with over 20 years of experience as a physician in policymaking and program design. And he's presently the Director of Policy Planning and Stakeholders Coordination at the National Agency for the Control of HIV. So over to you, Daniel.
Good evening, Dr. Honor, or good afternoon, please, or good morning, depending on where you're joining this call from. I want to appreciate you for the opportunity to be on this panel and to contribute to this discussion. Yes, I will start by saying SBCC is a very good strategy. But like prevention, over time, in a number of countries, Nigeria inclusive, started taking backstage, so also has SBCs. I remember in my early days in the response, SBCC was a very strong strategy employed, targeting various populations. But over time, it almost became absent in our national response. And but with this recognition of the fact that prevention has taken backstage, we are bringing it up again. And some of the reason behind it might be the fact that some donors might think it's a bit difficult to measure behavior change if you compare it to something like HIV testing services. It's easy to say, I tested 100 individuals, I find this number positive, I put them on treatment, and then I'm doing adherence, follow-up, and all that stuff. Now, and behavior change also takes time.
We seem to have lost the signal there. Your microphone's muted. Thanks.
Yeah, no, I think it was internet issue. I just came back now. Sorry.
Great, thanks.
But can you hear me now?
Yes, go ahead.
Okay, so fine. I don't know where I stopped, but I was saying why sometimes the funders seem not to be interested so much in SBCC, because unlike HIV testing services, it's easy to say the number of people tested. It's a bit difficult to say the same thing for social behavior change, and it takes time. But you see, if we're going to have a sustainable HIV prevention, we must fall back on social behavior change communication and the strategies. We also need to look at the fact that mental shift takes time. Information has it that knowledge does not immediately translate to change in behavior. So we should be prepared that it takes time. If a country is trying to do behavior change communication, they shouldn't be so much interested in having quick results. They must know the fact that it takes time, it takes process. And so some of the technical, some of the things that might be required of countries, going straight to what I'm asked to discuss, will be to look at the capacity of that country to both design behavior change interventions, So those skills are unique skills. It's not just passing messages to people. How are those messages developed? Especially the human-centered design approach. You need to get the people, and then people here is not only the population you are targeting with that intervention. Like we know behavior, there are certain things around that individual, which is maybe the immediate surrounding, the society at large, and all that. So messages must be targeted at those other structural barriers to also help that person in the center to be able to adopt the desired behavior change that is needed. So those are some of the things that the country will need skills to do that. We need fund to do that. We need well-defined strategy and timelines so that they don't expect results overnight for something that might take some time. And then another thing I want to say is beyond behavior change, Nigeria is even looking at more proactive. For example, instead of saying behavior change, can we even talk about behavior shaping? How do we shape the behavior? One of the approach Nigeria has adopted recently when it comes to prevention is to say, we don't need to wait for you to be high risk. We don't need to wait for you to come at the edge of a precipice before we say, let's begin to intervene with you. Sometimes it might already be a bit too late. What our data showed us, for example, is from the age of 15 to 19, the prevalence for female folks multiplied by 10 times when they are 35 years. For the male population, 20 times when they are around 50-something years. So it means there's something we are missing beyond all the biomedical interventions and treatment. What are the messages you are passing to the people? What are the full, complements of HIV interventions, especially preventive intervention that we can now bring in to flatten that curve, not to have 10 or to 20% increase in prevalence over the years. So we were even started saying, okay, as we engage with them at the age of, we are using 50 because that's what the data show, the naive is from the age of 15. But we can even go further down.
Sorry to interrupt, there's just about a minute left.
Okay, if we engage with, okay, so you engage with you, what are the messages we need to pass to them for self-worth, delayed gratification, to anticipate and handle peer pressures? In fact, one of the studies we did in our communication strategy for PrEP, you'll be surprised, some of the respondents said they are more interested in keeping their boyfriends than necessarily preventing themselves from HIV. So if my boyfriend must have sex without condom, and I need to keep that, but then I have to give it to him. So messages to address some of those things must come out clearly. I hope I'm not taking so much of your time. Thank you very much. Over.
Thank you so much, Dr. Ndukwe. And excellent points there. I think what we are bringing out is the relationship between these social contexts and the dynamics of behaviors and the relation between those things and commodities. Thanks very much. So please keep adding your questions to the Q&A. And I think we've got one theme coming out there through this first presentation. The second presenter is going to be Clemens Benedict, who's a senior advisor for the HIV Prevention or Global HIV Prevention Coalition at UNAIDS. He's worked at the coalition since 2018 and has been certainly a strong thinker in terms of how to respond to HIV prevention. And he's also got a long background in HIV and community responses. So Clemens, welcome. And just to stress, the presentations are 5 minutes. So I'll be butting in to advise on the time, but thanks very much and welcome.
Thanks so much, Warren. And yes, great discussion and questions. Let me just maybe go back with a few reflections on where social and behavior change programming sits within the global prevention architecture and guidance. You might remember actually in 2010, the UNAIDS investment framework for the HIV response had behavior change as one of the main thematic pillars. And you might also be aware that in the more recent guidance, including in the Global Prevention Coalition and the current strategy and targets, perhaps social and behavior change programs are less visible. But of course, even in the current guidance and the current framing of prevention, the framing around behavioral, structural, biomedical interventions is still relevant and in place. What happened in those discussions is that the social and behavior change programming work was integrated into what we call people-centered prevention pillars. So in the Prevention Coalition, we have 5 pillars of prevention, and 3 of them are actually people-centered pillars around HIV prevention. Combination prevention with key population is one of them. One is for adolescent girls and young women, and one is combination prevention for boys and men. And the assumption was that these programs, unlike the sort of more biomedical pillars like condoms and PrEP and harm reduction, VMMC, unlike those ones, these people-centered pillars would take a comprehensive view around the behavioral, structural, and service access dimensions of programs. And this actually, if you look at the funding for HIV programs in the past decade, when this framing has been in place, has actually also led to quite substantial investment in these types of programs. Probably the single largest in investments in the past decade have been programs for adolescent girls and young women, and they have, for this particular group, behavioral, structural, and biomedical interventions combined, often actually with the largest share of funding going to behavioral and structural intervention types. And for key population programs, similarly, we have actually, trusted access platforms, peer outreach approaches, enshrined in these programs and absorbing a substantial amount of resources as well. So the programs are still in place, but perhaps the very systematic design approach that Brian outlined has been lost to some extent. And in part that is due to the social behavior change paradigm having come under pressure. There have been questions, including from community, on the terminology. There was felt behavior change in particular is not an empowering terminology. There has been pushback on the effectiveness. And of course, we have seen evidence, and I think Annette posted it in the chat, that if we look at standalone behavioral interventions that aim to change sexual behavior, aiming at abstinence, or in changing injecting behavior for key populations, for example, have not been effective. We do have a few trials, very few trials, where we actually see that direct link between behavioral interventions and biological outcomes. The SHARE trial in Uganda showed that it's a very complex combined intervention. The Stepping Stone trials had an impact on HSV2. It's a sort of a multi-session community program, a very simple intergenerational sex interventions had an effect on teenage pregnancy as a proxy for sexual behavior change and reduced HIV effects. But in general, the aim of these behavioral intervention is not necessarily directly into incidence reduction. It's those immediate outcomes that Brian also mentioned, access to prevention options or different choices somebody is making through effects on all the factors that we saw in the model. Nevertheless, we have actually good learnings, and I think some of them were shared in this session from trials. We have I think insights from the behavior change model that can help us think through our options at country level.
Just to say there's a minute left.
Minute left. I'm coming to the end. And so what is important to consider is, at country level, when designing a national programs, it's not about exactly replicating a trial, nor, considering all elements of a model, right? If you look at the social ecological model, we will have to use this as a template, but then decide what are the most important, most feasible factors to address, what can we as programs influence, and that requires that country-led design and prioritization, which we maybe have left out a bit in the past years. And this is why we're currently thinking with the group in the Global Prevention Coalition on a revised, updated guide, perhaps with a different framing. And this is a question that is still under discussion because of that pushback. People-centered prevention, design, and communications doesn't capture everything on social behavior change, but covers some critical dimensions. Even the term social and behavior change doesn't cover all dimensions. So we're thinking on whether there's need for a new framing or not, but certainly some updated guidance can be looked out for. And of course, there's a lot of existing documents on elements, on key population, trusted access platforms. We have, guidance on scaled programming, similarly for adolescent girls and young women, how these programs can fit into a combined prevention approach. There's guidance on virtual interventions as well. Thanks so much.
Thank you so much, Clemens, and sorry to all the presenters that 5 minutes is a very short space of time to put forward some key points, but I think Clemens as well has provided us with a very good insight from the global perspective of how SBC is thought of in the response to HIV, and both the challenges to SBC as a concept, but also the opportunities. Great, so our next speaker is going to be Sarah Osman, who's a social and behavior change, behavioral science expert with extensive experience in sexual and reproductive health and rights. She's worked with MSI Reproductive Choices in South Africa, where work included advocating for the integration of SRHR and HIV services. She's also conducted research on the psychosocial determinants of condom use among young Ghanaians in urban settings. And in her consulting work, she's a member of the technical review panel for Amplifying Change and SRHR Challenge Fund. So thanks very much, Sarah. Go ahead, and also just to note the 5 minutes, hopefully I won't have to constrain the key elements of your presentation, but thanks very much, and we look forward to your presentation.
No problem. Thank you, Warren, and thank you so much to the Learning Network for having me. And thank you for everyone for attending. So Warren, I'm going to keep it very short and to the point. So I want to zoom in a little bit onto the issue of relationship dynamics and touch a little bit on stigma. And although, we know that SBC works and it has a lot of potential for helping us improve our HIV prevention efforts, I think that we can also update our SBC methodologies to be a little bit more responsive to some of the challenges that we're seeing. So one of the things that I feel that we need to update urgently is the way that we are conducting formative research or understanding what people are going through as they are making their decisions. So we still have an over-reliance on focus group discussions, for example, and this does not really help us to understand where people get stuck as they are, going about their lives and, engaging on trying to be better on their sexual health journey. So I think that we need to look at methodologies like life mapping, for instance, to understand the experience of a young woman that has more than one sexual partner, perhaps an older sexual partner and a younger one. And how does she navigate and make her decisions, and what derails her decisions? So even if she, decides to get on PrEP or what have you, what derails that? So I think that's one thing that we urgently need to look at. And luckily, with AI and with technology, we are able to do research and, kind of adopt new methodologies that could help us do that in a much more cost-effective and personalized way. And I can send you guys some resources on Gen AI if you're interested. The other thing that we definitely need more of is infusing more clinical psychology into the way that we design HIV prevention interventions from an SBC lens. And I think a great example of how that is done is the Coach and Pilo program that Brian has shared. So we really, again, need to zoom into that personal experience. What is the person going through? Because HIV is such a heavily stigmatized issue. So we're dealing with self-stigma, we're dealing with community stigma, we're dealing with service provider stigma. And you know, I don't believe that we've tapped into clinical psychology enough in the way that we are designing some of our interventions. And we increasingly see, for instance, that social support is a critical element in HIV prevention efforts. But we are still relying on methodologies that are maybe not sufficient to help us really design effective social support elements. And then the last point that I want to touch on is, I mean, this might be a little bit controversial, but I think that if we want to have social change, so if you want to focus on the S of SBC and truly make gains towards sexual health, we need to be more sex positive in our messaging, and we definitely need to improve the way that our comprehensive sexuality education programs are designed. So, you know, before we are anywhere near it being too late, as Dr. Ndukwe was talking about, we need to have, you know, young people who are empowered, who understand their bodies, who understand what sexual health is. And that simply requires sex positivity. I think Brian was being very optimistic, saying that, you know, ABC is a thing of the past. But unfortunately, I think we're still doing a lot of ABC. And that is just, it's just not working. So that's definitely something that we urgently need to look at. And I mean, maybe I'm a little bit biased, but I do believe that we also need to incorporate HIV more closely within an SRHR framework, and that will help us to get rid of a lot of the stigma that's associated with HIV. So I will keep it at that for now, and I hope to keep the discussion going with you. Thank you so much.
Thanks so much for that those excellent insights. So just in terms of where we are, we've got one more presenter. There are also a fair number of questions in the Q&A box. What I'd like to do is encourage the presenters to just go through that and select a question to respond to, see which one you feel you could respond to best, and then we'll give 2 minutes for each of those responses, just because there are many questions. But we'll also bear in mind these questions for ongoing work and webinars and so on in this area. So with that said, I'd like to introduce, so you've seen different perspectives from government, from UNAIDS, from the point of view of psychology. And now we're going to have Kenneth Malundo, who is a practitioner, a SBC practitioner. So he's got a lot of experience and background in actually conducting SBC interventions in many different fields, not just HIV, but excellent experience working with lots of different international organizations. And Ken currently leads a social and behavior change consulting firm called Solutions for People, based in Uganda. And he also volunteers as the interim secretary general for the African Society for Behavior Change. And you'll see also the African Society for Behavior Change is hosting a conference on SBC next month, or I think it's July, actually. So without further ado, thanks very much, Ken. Welcome, and we look forward to your presentation.
Well, thank you, Warren, and thank you, fellow panelists who have made good presentations. And also, thank you, Brian, for that insightful presentation that you made. I was going to what I'll be discussing is basically how can application of theory of change enhance the design and implementation of an SBC intervention aimed at bring about a meaningful change in the context of HIV prevention and care. And when we thought about it, we realized that, one, Brian just mentioned that we have about 12 interventions that we put out now for HIV in terms of our menu. I would want to highlight one of those as an example that I'll use through my discussion through the 5 minutes. And I'll talk about the voluntary medical male circumcision, which was introduced in Uganda. I think around 2009, 2008, it was introduced in Uganda. At that point, the focus was 29 years and below, which gave us a good prevalence because it was a bit of a stylish thing that it was portrayed. So we had about 60% prevalence of people who actually took on the service. But I wanted to highlight the 20-year-old in 2010, who's now 34 years probably. And Uganda sort of tried to move to that level of saying we want to focus on the 30-plus-year-old. And it's not easy. It's not being easy for them to get that person. I think the targets from some of the from the donors and partners are quite difficult to achieve for this young man of 30 years. One, the man is running away from being cut. He's simply the mobilization approaches that are being put out and demand creation activities don't really appeal to him, or they don't actually are not in line with what's happening with this young man. They're not tailored to his unique needs. He's in a different place. His challenges, he's beginning a family. He's getting his first meaningful employment opportunity. He's beginning to construct his own home. So he's becoming a man. And at that point, you're telling him about this circumcision, and he's like, why do I need it? So it's difficult to get that person. And we're totally missing that person in the case of Uganda. Now, this is how theory and the theory of change, Brian sort of talked about the socio-ecological model, and he made very, very big emphasis on the socio-ecological model and how it can help us layer our interventions from individual to the interpersonal and all the other spheres of the socio-ecological model. What I'm interested in now is to see how can we bring out that theory and make sense of it in our context of this young man I'm talking about. What we see is let's treat these HIV interventions as innovations, and I wanted us to apply the diffusion of innovations as a theory that could help us to have a better understanding that we are bringing out interventions which are basically innovations, but how do we build them into tangible? How do we avoid bundling them into one big thing and say this is about HIV and this is what you have at your disposal for prevention and care? How do we unpack that from the diffusion of innovations? And I was saying that one, this young man now, when we look at the diffusion of innovations, is basically falling between the early majority, a bit of the late majority, and also he falls into a bit of the laggards. He's sort of resigned to his situation. So from our campaigns that we roll out, which are basically branded and mass media, and the old VHT, the village health team member who goes to the interpersonal, may not be the right person for this young man. Now, this is what they will tell us to do. They will tell us that we require maybe deeper explanation and engagement for this young man around our circumcision programming. Theory will tell us that maybe we need to look into his connection moments to know when this man likely to take our messaging and take our intervention. And that's what theory is going to help us unpack in terms of HIV. Theory will help us move away from that VHT, who's basically now an old retired person in the village, or a teacher in the village, and move to a network or a peer that appeals to this young man. So looking at his network. Then again, theory helps us
about a minute left, Ken.
How do we use radio and how. Okay, yes, I'm done. Theory helps us look at how radio is being used in the same way that we might require more engagement beyond that. So in terms of, as I conclude, I wanted to focus on the diffusion of innovations theory to address one, individual benefits, group benefits, and also help us address those individual resistances that someone might have, and also the group demonstrate trust within the HIV programming and bring out all those things together that someone actually is able to believe in our programming and uptake of service. And that's what SBC can bring to the table. Thank you very much.
Thank you so much, Ken, and to all the presenters in this session. So, as I mentioned, we've got about 2 minutes for each presenter to respond to questions that are on the Q&A. Sorry, it's such a short space of time, but we're going to do our best, and then we'll round off towards the end of this. But we do want to keep on time. So I'm just going to go in the sequence of the presenters as well. So the first presenter was Daniel. If you can respond to a question that you saw and give us a quick 2-minute response.
All right. There's a particular question that was asking about how, so if I rephrase the question, looking at a multi-sectoral approach, for instance, to HIV prevention and SBCs as well. So I would rather say the experience we have, for example, back home here in Nigeria is as we're going towards the sustainability of HIV, you realize different sectors have got a role to play. So what I'll put on the floor now is to say, you need to have a body that has coordination skills that bring these various sectors so that all effort can be geared towards achieving a particular objective. Is very, 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 very important. Because prevention has various dimensions: empowerment, education, so on and so forth, biomedical intervention. There are so many. So no one sector can do it all. So I have a very strong coordinating entity that can bring them together. Thank you, Anova.
Excellent. Thank you very much for that. So we'll move on to the next presenter. So that was Clemens. If you can just respond to a question you've seen. Your mic is mute.
Thanks so much. Thanks so much. A specific question.
Sorry, Clemens, we seem to have lost you again.
Sorry, would you like to me to respond to a specific question, because there's
either that, or if you see some general points coming out of the questions, feel free to respond to that as well.
Well, maybe I'll pick up on Saul's point, saying, you know, it's really the challenges that we have is often between a very broad range of factors we can address and issues we can address, and then, you know, a very reductionist approach that just focuses on, you know, creating demand or communicating about a service or a product, is to find the sweet spot. And that is, as Saul said, often much an art, more an art than a science, because some of the most comprehensive models that we have, maybe from trials or from other work, are often not scalable in the same way. And I feel we may have in the past years often gone very broad and fragmented in trying to address, you know, for small populations, often even remotely related factors. And we haven't necessarily had that very systematic look on how can we use these behavioral norms changing and other factors and interventions to actually influence core prevention outcomes. So maybe our task, and of course that's up for discussion, is to bring the things closer together. So apply the behavioral lens, apply the norms changing lens, but really in relation to what, you know, the effective prevention options for today are. And I think this is the scope of the work that's probably ahead of us. So maybe watch out for this space with the SSLN and other partners working with the GPC to advance maybe you know, a new or slightly revised framing. Thanks.
Thanks so much for those points, Clemens. And let's move on then to Sarah.
Thanks, Warren. I think people mostly want some resources where they can learn more. So I'm recommending the Compass for SBC, which has a lot of fantastic resources, and then the Communication Initiative, which also does really great summaries of studies. And then I will also link in there a community of practice that you can join if you want to learn more about generative AI and SBC.
Thank you so much for that, Sarah. So, and let's go ahead with Ken. Ken, if you can respond to either one question or the questions as a whole.
Dan, I haven't seen any specific question from my side, but I think what I saw in the chat here was around how interventions are being considered around HIV/AIDS, and I thought one important critical point that we could bring on the table is also the use of behavior science, and how would we be able to model and create some nudges within our programming for HIV, and I thought that's a critical thing to address what has been put in the chat in terms of the different interventions we have. Thank you.
Excellent, and thank you to all the presenters for your presentations and for the points you've raised in the discussion and comments as well. So I think the main issue here is thinking about how SBC can be brought more centrally within the HIV response. I think just to stress that SBC didn't go away in every single area of response and behavior change. It's used very, very widely in other aspects of health and development, and very successfully. One other point I think I need to stress is there's a huge number of people and a growing body of people who are experts in this field working in health or related areas, are using SBC modalities, theories and models and approaches. So there's a lot of experience and skills to draw from. And I'd certainly encourage also looking a little bit more widely at how SBC has been helpful in other areas of response. So excellent, but thanks very much for all your questions as well. I'm sure this is just the beginning of a longer series of discussions around SBC and integrating SBC into the HIV response. And I'll hand over back to Dr. Ona, who's going to round off our discussions for today. But thank you very much, everyone, once again.
Thank you so much, Warren, for such a very wonderful Q&A session. And thank you all the panelists for your quite insightful information. It was really, really good to know what the different perspectives as we talk about social and behavioral change for HIV prevention. Maybe just, I can see my clock, I have a bit of a 7-minute round-up time. Is there anyone from the attendees who would like to ask a question, and just for 2 minutes or 3 before I wind up? To be glad to hear. Okay, now, thank you. Okay, Owagang Maseki, please, I've seen your hand. You're welcome. Yes. Owagang Moseki, please.
Yeah, good afternoon. I did ask a question earlier on to say that normally we have issues regarding to people reached with health messages. I just wanted to know, according to your own understanding, how do you define reach in terms of people reached with HIV messages? We encounter a problem when we request our partners to report on the number of people reached, because sometimes people say, for you to have reached a person or individuals, you need to have reached that person more than 3 times. So I just want to know your understanding with regard to that. Thank you.
Okay, maybe I'll pass that to Dr. Ndukwe. If you could reply to that, how do we define reach?
Well, I don't know that I'm in the best position to answer that question, but because for reach, are you looking at it? Okay, fine. Now, in our program, when we were our SBCC, so one of the approach we did when we were doing what to call our combination prevention approach, okay, for HIV prevention, and SBC is one of them. So not just the messaging alone. We are supposed to reach a particular client. So I'm not just the figure, but I think it's a total of like I think 3 to 4 times for that period for a particular cohort. So I don't have a figure offhand, but so they continue to define what program they approach and the approach. So we were doing like if you meet them like once or twice in a month for a period of like 9 months, you'd have reached that cohort. You'd have talked about so many things because it's also such meeting. You also used to give them some of their products, medical products like condom, lubricant, and what have you. So it depends on that structure. I think the country has to decide what works for them and how they want to measure it in the indicators. Over.
Okay, thank you, Dr. Nduga. Maybe Brian, if you want to add before I chip in.
Yeah, so I would just clarify that, you know, the 3 exposure or 3 engagement rule is, I don't think it's based on anything specific. It's just sort of this better practice that we want to make sure that we're engaging with people multiple times before we anticipate any change in attitudes or beliefs or any of those things. But I do want to just reinforce the idea that it really is important to measure reach, which we don't always do in many of our SBC programs, because we need to know how many people and what proportion of our intended audience are actually interacting with our interventions, because that is the type of information that we need to later demonstrate that those people that we engaged with, those people that were exposed to our interventions, actually exhibit differences in terms of level of knowledge, level of perceptions about social norms, and also behavior. You know, measurement in behavior change programs is difficult, and it's different from measurement in clinical programs. But yes, measuring reach is really important. But again, how many times you need to reach someone before they change their behavior it's really dependent on the behavior you're asking them to adopt, the context that they're living in. So I'm sorry, I don't have a firm answer to say you need to reach people X number of times. It really just depends. But again, I think the key message is that it's important to engage people multiple times before we can anticipate any change in either the factors influencing behaviors or ultimately the behavior.
Okay, thank you so much, Brian. I think you have said it all. And looking at my time, I probably wind up by saying, first of all, thank you for really your great participation. I can see we had a lot of very informative information. Thank you for those who have been able to put some questions in the Q&A. And also we have seen some of the very insightful critical points being shared through the chat box. We are really very delighted for all your participants. Thank you for your engagement. Thank you for thoughtful questions that you bring on the field and actually your active participation. I think I have few takeaways, but social behavioral change, just to highlight, is still a continuous process. It's dynamic. It is not static, and eventually it requires a very sustained effort and empathy and adaptability. I know you've heard of the socio-ecological model, which caters at all dimensions, that we need to have an holistic approach as we consider the social, economic, cultural, and psychological factors to play. So basically, this is the call to everyone from the government, the policies, the agencies, that we should continue to remain committed. We have received some of these insightful inputs today, and actually it is very, very important. I've heard of many, many good things that probably I like to go back and relook on how I conduct my SBC approaches in the country. And since SBC is cross-cutting, it's basically you cannot you cannot talk of combination prevention for HIV without the aspect of SBCCs. Like it's must be there whenever you continue with your intervention. So I'd like also to thank the organizers and everyone here. So see you around. All these will be recorded and will be put in the website, and also we will share everything here. You can see the link. We have the links from the X, the Facebook, the LinkedIn, and also you have recordings through our website, www.hivinterchange.com, and also the recordings will be available at YouTube. So thank you all. See you next time. Have a good one there. Ciao, ciao.